Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
Welcome to the Pod of Inquiry. This week's episode is a continuation of last week's episode where I had Dr. Sonny Yamasaki and Dr. Scott Nickerson on to start the discussion of nerve decompression surgery in patients with diabetic peripheral neuropathy and how this surgery can improve what is known as pressure-induced vasodilation. I highly encourage you that if you haven't listened to last week's episode, to go back and listen to it. It was season 4, episode 18, before jumping into this episode. It will give you just that much more foundation and a little bit more understanding and appreciation of how important this surgery really is in preventing diabetic foot ulcerations, as well as just improving the quality of life for so many people. Dr. Nickerson, as I introduced in last week's episode, is a retired orthopedic surgeon who was actually forced into retirement by symptoms of diabetic peripheral neuropathy. He then subsequently had nerve decompression surgery, saw great effects, and has been basically out teaching and writing about this for the last 20 years. Dr. Yamasaki, as we talked about, is an incredible neurophysiologist who had a long stint at Medtronic where he was a technical fellow and lead stroke expert. He also was an assistant professor at the University of Wisconsin Medical School, and he now runs and is the co-founder of Enso Medical Technologies. Please enjoy this wonderful conversation and continuation of last week's great conversation on the Pod of Inquiry.
So the summary here about diabetic foot ulcer and skin blood flow is that we can connect all these things by the polyol metabolic pathway. Step 1 is the polyol pathway becomes more important in the ability of the nerves to control by sympathetic management the blood flow to the skin. And that happens because of this osmotic balance from the polyol metabolic path, creating fluid migration, the fat axon, and in the areas where there isn't available space, which are fibroosseous tunnels, you get an increase in pressure with compression neuropathy going rather high. We know that if you get to 150 millimeters of mercury pressure, that all nerve transmission will stop. Well, this is a good deal more than halfway there. Mm-hmm. So with these autonomic dysfunctions and the increase in AV shunting, we then get vascular capture, which steals the skin microcirculations. You then get the skin hypoxia, diabetic foot ulcer develops, and when you do this nerve decompression by means of epineurolysis surgery, you can relieve compression that would be occurring at the fibroosseous tunnels, and this rejuvenates the autonomic supply to the vascular control. Sonny, do you have any interjection here?
No, I don't. That was beautifully described. Steve, it would be interesting to hear your perspective based on anecdotal data that you see in your patients. You know, I've seen cases where they're seeing an improvement as soon as the anesthesia wears off.
Right. I think from if we're going to focus into this very small component in this big physiological picture, one of the things that I found very interesting when I first started doing these decompression surgeries was that at about 3 or 4 weeks, patients would often come in and they would say, look, the color of this foot and the skin are totally different than the one that you haven't done, and differ in an improved manner. They had clearly better improved cutaneous blood flow, as well as, improved macro circulation. So that was really and I'll have to go back, but I've got some photos of some of these patients where you look at one of the extremities looks like it's just coming out of a museum of Egyptology, because it almost looks like it's just mummified skin, and the other is nice normal pink skin. And I think that was really very interesting, going from wow, we're seeing this to we always see it. It's just one of those things that you clearly saw these improvements in autonomic function from the texture and the quality of the skin. So it makes a lot of sense. But where I wanted to go back to that vaso-induced or the pressure-induced vasodilation. Scott, Sonny, do you know the mechanism of that? Is it that maybe there's some shearing force that's increasing, local nitric oxide production, or is it, what's going on from, what is it, where does it go from the mechanical stimulation to what's happening in the microcirculation?
There are papers about this, Steve, and they say that the PIV can be affected 2 ways. One is by the nitrous oxide endothelial source, and the other is a chemical one that's nitroprusside. And there are certain laboratory animals that do demonstrate PIV, and it's a mouse and the rat as well as the human. And so there is laboratory work that shows that that nerve decompression will restore this loss of PIV that occurs sequentially as nerve decompression develops. So it's basically using the Dellon sciatic nerve encirclement model to show progressive loss of PIV, and then nerve decompression restores this. Nobody's done this clinically in the human yet, but they have done human studies that show increased TCPO2 after nerve decompression, and that's the chronic capillary ischemia resolution.
Well, we saw that as well at our study that we yet to get published with the laser Doppler flow.
So to expand on what you said, Scott, as far as the nitric oxide component, so let me explain it in a mechanized version or example. So when you put pressure on the skin of the foot by standing or walking, you're actually occluding the capillaries, right? And you're occluding, more importantly, the arteries and the arterioles. And what happens in that scenario is you create an ischemic event downstream where you have a reduction in blood flow because of these compression weight on your foot. So what happens with healthy endothelial cells that are lining the arteries and arterioles, they're going in response to this ischemic event, they're going to release nitric oxide. So nitric oxide, again, in healthy endothelial cells will flow downstream, which will cause a downstream vasodilation. And that's the presumed mechanism here. It may be more complex than that, but that's at least the nitric oxide component.
So, Sonny, let me follow up on that then. You also think that because we get an improvement in autonomic function post-decompression, that's playing a role in the AV shunting, as Scott just pointed out on this diagram previously?
In regard to endothelial cells, I don't see how you would get an immediate improvement in the endothelial cell function I do see that nerve decompression over time might improve the health of the endothelial cells.
Right.
I don't see it happening immediately, though.
Okay.
And one of the outcomes of that longer term, Sonny, is that the relief of pain continues to improve over months in Shirosam's paper. And then the other thing is this second Volasubramanian paper that I mentioned that you and I haven't talked about. It does use just manual occlusion of the dorsalis pedis or posterior tibial arteries, and then shows improvement in the flare reaction.
Steve, I don't think I was clear in my answer to your question, and that is, I don't see how nerve decompression will improve an unhealthy endothelial cell right away. Here, we're not talking about unhealthy endothelial cells. These are healthy, normally functioning endothelial cells that respond with the release of nitric oxide and an increase in flow. So it would be where you don't see that, where you don't have a PIV increase in flow, that might be due to an unhealthy endothelial cell. And in that case, I don't know that a nerve decompression will help, at least immediately.
Well, what I was trying to get at, and I'm not sure that you've given me the answer, you probably not, I'm not smart enough to understand it yet, but what I'm wondering is if we're able to positively affect the function of the AV shunt by basically restoration from the dysautonomia, that has to play a role in what we're seeing with people that get improved pressure-reduced vasodilation after nerve decompression. Or am I totally wrong?
I think that's true.
Yeah, I think that's true.
Okay. So it's a combination then of the nitric oxide event as well as the improvement in the autonomic function.
Yeah, it will be interesting for me to read your paper with Andy Rader and see if anesthetizing the autonomics, which presumably will happen with a lidocaine injection, will also turn off the AV shunt, or actually.
Well, Sonny, I don't think we're shutting off the autonomic function. I think we're improving the autonomic function because we see, the pattern has no local anesthetic agent effect whatsoever, and we're using such small. We're using 0.2 to 0.3 of the cc up next to the common fibular nerve at where it's its normal side ventrale at the fibular neck. So we're not really looking at any anesthetic effect so much, but I think we're seeing an almost instantaneous somewhat improvement because we saw huge changes in dorsalis pedis waveforms immediately after the block, whether it's papaverin or just plain lidocaine. So I think that you would see that if you put way too much in and you created a droplet sort of. But I think I don't know if you remember this study, but when we first observed the Phoenix sign, you were one of the first in Scouts, one of the first people that I sent this to, because this was just ridiculous. It didn't make any sense that we were seeing this clinically. And then there were all types of hypotheses. Was it really something going on with modulation from a neurological modulation, or was it just, and I'm just a dumb old country boy, so I just thought, well, there's vasodilatation with a local anesthetic unless it's cocaine. I think it's the only local anesthetic that has vasoconstriction. But long story short, I felt that it was just an improved vascular event that we were seeing that was taking this nerve that was compressed and had focal ischemia. We were delivering a little bit more blood flow to it, so it consequently could function for 4 to 10 minutes before that effect of the vasodilation wore off. And then we just got a paper approved for publication in JAPMA where we compared papaverin to lidocaine, and it was double-blinded, randomized, prospective, and we didn't see any difference. So I think that, nothing's proved yet, but that's pretty compelling evidence that it's more about an improved vascular phenomena rather than some occult neurological.
And what Sonny may not understand is your outcome measure was strength of various foot muscles, which was the positive outcome.
Right. Yeah. So the first studies, we were just measuring motor strength. Because these people came in, they had a drop foot for 5 years. They were told nothing could be done. And when we first started looking at this and made this observation, we weren't trying to restore function from a dorsiflexion standpoint. We were just trying to eliminate pain in these, they would come in, it's like, yeah, I have this drop foot, but I know I'll never get that back, but is there anything you can do for pain? And so we put a little lidocaine next to the nerve, and then one day, all of a sudden, this patient who hadn't dorsiflexed in 5 years got complete sensation back. I sent you guys that. I think we made some real short videos. And that was like the first time we had seen this, like, wow. I mean, I know this has happened before, but nobody ever made that observation. So that's kind of, I know we got off track a little bit about that, but I think it dovetails into, what we're doing here with the decompression.
So papaverin is a phosphodiesterase inhibitor, just like Viagra, right?
Right.
The PD5 inhibitor, but so papaverin in and of itself will cause vasodilation, right? And would that be how you're seeing an improvement in flow?
Well, I don't think so, because we're only using, like 0.3 of a cc way up in, up north by the common fibular neck, right? Or fibular neck. And so I don't see how that would create any systemic vasodilation from that small of an aliquot that far proximal to where we're seeing the changes in the function.
Yeah. This is interesting. I'll look into this, Steve.
Yeah, I think your perspective on this from a neurophysiology point of view would be really welcome, because, sometimes when you see these things clinically, they're like, there's so much physiology that's going on behind the scenes that until you start really peering behind the curtains, you don't really have a great idea of all of the things that could be going on. But again, we're just very early on at this stage.
Steve, you must have a proof of that JAPMA article, right?
I don't yet. We've been
accepted, though.
Yeah, we got accepted about 4 months ago. I'm still waiting for it right now. I can send you guys just a word draft of it. Take a peek.
Hey, I believe I still have that. Well, maybe I haven't seen the final draft. Yeah.
Okay. So Scott, you mentioned some of Shai Rosen's work. Do you want to start going into that? Because I think that's a really important thing. Or you want to finish up here?
One more slide.
Okay.
Which shows what Sonny and I have found reading all the papers that talked about diabetic foot ulcer recurrence risk. And this is the slide, and I summarize it on the right, but there are 7 papers on the left that we found that had nerve decompression, and we could get information about ulcer occurrence or recurrence. That's what this table shows. And the summary is then on the right. I got to move my videos. Okay. So there are 7 studies. All of these people were International Working Group on Diabetic Foot Risk Class 3. That means they'd had a prior ulcer. And so they're in those papers. There are over 500 cases. 73 of them had an active neuropathic diabetic foot ulcer. The others had a prior healed diabetic foot ulcer. So in those 526 cases, you would expect in 1 year, according to the big New England Journal article, that you'd get about a 40% recurrence risk if they were a mix of both neuroischemic and neuropathic ulcers. Well, we had only 13 recurrences in a total of 1 to 3 year follow-up, totaling 973 years of follow-up and only 13 recurrences. There were no amputations in that follow-up, even though everybody had either an active or a prior ulcer. So the annual diabetic foot ulcer recurrence risk was under 2%. And that's an astounding figure. And this is what we put out in the article. So we think that this ought to draw some real interest in people doing prospective randomized control studies, of which the AENS has not been able to get together, even though we've gotten a protocol to do that. So that's kind of the summary of what we are able to tell us about nerve decompression, sympathetic control of skin circulation, and diabetic foot ulcer recurrences. But then we can go and talk about the results with pain after nerve decompression in diabetic peripheral neuropathy. So we've got a couple of slides about that. To connect DPN and pain, this new article from Dr. Rosen and people who were associated with him at the University of Texas Southwestern. These included people in plastic surgery, Dr. Rosen, neurology, endocrinology, physical medicine, and rehabilitation. I think there are 8 or 9 co-authors. So this really involved everybody who ought to be concerned about diabetic pain. And his results, he showed these to us in 2016 at the AENS symposium, and he has 4 groups of people who had who were in the study. There was a control group that had Likert visual analog pain scales that started out at about 8, and over the ensuing 1 year and 4 years, he followed up these people to see what was their pain. They were treated with just standard diabetic care, and there was no nerve decompression offered or added. Then he had people that did have nerve decompression, and this study was set up so that one leg had compressions decompressed, and the opposite leg had a sham surgery where skin only was opened and sewed back up, and then the pain was compared over a period of time. And his results showed that not only did you relieve the operated pain that had nerve decompression, that would be the blue line, but that you also had a lesser degree of pain relief in the sham-operated contralateral leg, which had only a skin incision that was sewn back up. Now, this is very disturbing to the endocrinologists and the neurologists because they wouldn't think that you could have contralateral improvement in pain by doing an ipsilateral nerve decompression. And I'm going to let Sonny talk about how that happened, because there are very good physiological explanations for how you can have contralateral pain improvement when you do ipsilateral nerve decompression.
Both anatomical and physiologic evidence. And this is just a hypothesis at this point, but it's, I used to teach the spinal cord at the University of Wisconsin Medical School. And unlike most medical schools, I asked doctors, how many lectures or how many hours of spinal cord did you receive? And most people would say 2, maybe 3 hours. I taught 11 hours of spinal cord anatomy and physiology. And one of the lectures was on the spinothalamic system. So most doctors today will think of the spinothalamic system as the what's known as the neo-spinothalamic system, which is predominantly contralateral. But there's also an archy spinothalamic tract and a paleo-spinothalamic tract. And in both of those, it's much more bilateral. It's still heavily contralateral, but there is some bilateral component to it. And what becomes interesting in the context of pain is, imagine pain on one leg, for instance. In the neospinothalamic tract, that's running up predominantly contralaterally in the spinal cord. In the archy and paleo spinothalamic tracts, they're running up bilateral in the spinal cord, and they're sending axonal circuits to the reticular formation. And it's the part of the reticular formation that is receiving anti-pain chemicals. So, for instance, gabapentin and pregabalin and those sorts of drugs, those are all being seen in the same part of the reticular formation that the paleo and spinal thalamic tracts are projecting into. So you can imagine that you could see an improvement in the contralateral leg because of this bilateral projection up to the brainstem and into the pain-related, pain-minimizing part of the reticular formation.
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. This episode is sponsored by Savant Cellars, providers of boutique Tier 1 Reds at a Tier 2 price point. Let's imagine you are spelunking in a cave out in Napa Valley, and you come across some of the juice from Savant Cellars. You may just never want to come out until it's gone. Savant Cellars sources all of their fruit from the really big-name boutique vineyards. That's right, where the elites get their fruit. If we put a vineyard designation on our bottles, we would be contractually forced to sell our wines at 3 to 4 times our current pricing. Yes, full disclosure, I am one of the 3 principals and I'm very proud of our wines. Savant Cellars is the genius of wine. Simply great wines, vintage after vintage, crafted in a Bordeaux style so you can lay them down for years or drink them now. They simply just get better. Use the code SPELUNK15 to get a 15% discount at savantcellars.com. That is CEVANT sellers.com. Spelunk15.
You know, it's real interesting because we talked about some of the things that we had seen clinically when we were first starting to do these patients. And I remember that I thought a lot of them were totally crazy because they would come in and they'd say, I know you only operate on the left leg or the right leg or whatever it was, but my other leg feels much better. Should that be the case? And I said, well, I don't know, maybe, and then I don't know if you remember Ian Carroll from Stanford came and gave a great lecture at one of the ANS meetings where he talked about the fact that there were some of these neuropeptides that would, if you had a chronic pain generator from one extremity versus the other, there would still be some of these neuropeptides that would leak across the entire spinal cord. And so maybe, that was being picked up as a perception of the other leg. And when you decrease that pain, maybe you were decreasing some of these neuropeptides that were mediators or nociceptors, whatever you want to call. But we did see that clinic. I mean, again, more often than not.
Very interesting.
And interestingly, I've always considered that the people who didn't come back for that second operation, they may have gotten adequate pain relief, but it didn't change anything about their risk of diabetic foot ulcer occurrence or recurrence or toe amputation. It's that other leg, to me, didn't have any protection from the nerve decompression. And I'm saying to myself, I wonder if that isn't the afferent, efferent sympathetic systems being limited to the spinal cord level. Pain comes up, sympathetic pain comes up, sympathetic control comes down efferently to the microvasculature, and that's why you don't get any protection from that non-operated leg from the nerve decompression.
Yeah.
He hasn't blessed that interpretation yet, but that's what I'm wondering.
I'll have to think about that some more, Scott.
Well, I think, Scott, one of the things that you pointed out, and I can't remember what was it, 1.7 or what was the recurrence in your in the recent publication?
1.39.
Okay, 1.39. If you look at just the standard numbers, it's as high as 40% per year.
Yeah,
Yeah. So, I mean, this is like a grand slam home run times 100.
that's the way I've looked at it. And the early studies, Dylan said, why don't you look at recurrences in people who've had nerve decompression after healing an ulcer? And even in those people, we had numbers under 5%. I think it was 4.6%. And then following them out year after, first paper was 2.5-year follow-up. And then I added 3 years onto that. And it ended up being lesser risk as time went on. The bigger risk is in that first year, apparently, and then it kind of tapers off as far as increased risk. And that's why at 60, you get 60% recurrence risk by the time 3 years have come along. But it's not a tripling of the 40%.
Right.
So that's kind of...
But it's still astronomical compared to, and I did an episode with David Armstrong maybe a year ago, and that episode was just simply dedicated on recurrent ulcerations. And it's not, a lot of times people think that it's the same location that the ulcer occurs, but most of the time it's not. It's in other areas.
Only 17% of next ulcers are at the primary location.
Very interesting. Which speaks more to the physiology of what we're addressing here, Eden.
Yes.
So fascinating. So when people, let's look at this graph just for a second here, because a lot of people are going to say, oh, well, the sham leg was just as good as the neurolysis leg, and so you didn't prove anything. But they have to understand that this was a sham leg done at the time that the other leg was done.
Yes, and the other thing is there is a statistically significant difference between sham leg and ND leg. ND leg is better.
Okay.
And I can't remember whether it's P value of 0.4 or something like 0.04, somewhere in that. And Shiro's the paper has it, but I didn't pull it out for today.
Yep.
An interesting thought just occurred to me looking at this graph, and it takes you back to the gate theory of pain, right? Mm-hmm. So let's consider the sham operated leg, where the skin is incised and then sewn back together again. That could activate the gate circuitry, where the rapidly conducting sensory axons are going into the spinal cord, sending their inhibitory branch down to the neurons the secondary neurons that go up the spinal thalamic tract. At least I don't expect that would happen for a year and 4.5 years, but it's interesting to think about what that might be doing in regard to the gate theory. Maybe it's activating the gate. It would be interesting to look more deeply into this.
This is this graph is the one directly from Shai's paper just published this year, and the decrease in pain is very rapid for both sham leg and the other the operated leg. So if the gate theory is involved with pain from that incision on the sham leg, I would think that would be a short acting duration, and
that's right.
It isn't. Yeah. Right.
Yeah, but it would be interesting to look at the gate theory itself more deeply to see how this might be related, long-term effect. I think the gate theory in and of itself is a pretty simplistic theory, and it does have some drawbacks to it.
Yeah, things are more complex than it deals with.
Mm-hmm. Yeah.
Like all of this about archeo and paleo systems is something I'd never understood at all, and I don't think it was considered by Melzack and those folks talking about gate theory.
It would be interesting to talk to Dr. Rosen about this, about the bilateral archae and paleo systems.
Well, in his paper, he he dives into how do I explain this as a placebo effect. And so I think he's, still running down the wrong path as to laying a lot of this benefit off as placebo effect. I think the deeper understanding of the pain pathways and appreciation in the brain is the answer. But I'm kind of limited in my depth of understanding of those things as to how to explain it.
One thing that the bilateral system doesn't really explain is you wouldn't have expected an almost equal, they're statistically significantly different, but almost equal effect. You would expect to see an improvement in the sham leg or the contralateral side, but not necessarily that much of an effect. I think if I remember correctly, the bilateral component in those systems is more like 10%. It's not like 50%.
Yeah, bilateral. Excuse me. There. This is pain. Afferent pain impulses are staying ipsilateral in 10 to 15%. That was my understanding from the Melzack, the latest update of that pain book.
Good.
So was there something more then, Scott, that you wanted to talk about with Shai's work? Because this is an incredible study. I mean, can you give, just for the audience, I mean, we know how much this went in, and we're talking, the last I heard, it was a couple of $1 million that was put into this.
That was my understanding, nearly $2 million when he talked about it with us in 2016.
Right. So this was a very robust study, maybe one of the most robust that has been published on this.
I think it's head and shoulders above everything. But the interesting thing is that Shai, I understand from Eric Williams that Shai sent this to, sent and was rejected by 4 general medicine or like New England Journal or British Medical Journal. He sent it to 4 journals and couldn't get any takers, and finally he said, well, it goes in Annals of Surgery then.
Right.
So that's disappointing that nobody could think, more broadly about this. And I think the main thing is that people have been stuck on what's the etiology. And I think what Sonny and I are putting out in front of people is that here is a plausible explanation of what's going on that explains why the scalpel can take care of these metabolic problems.
Well, go ahead.
I'm sorry.
Go ahead.
What you said about Melzack, it jogged my memory. So for those listening, Ron Melzack is half of the discoverers of the gate theory. So it's Pat Wall and Ron Melzack that in, I think, 1965 published their first paper on the gate theory. And this has always stuck with me, not only because it's an interesting hypothesis or theory, but because when I was in graduate school, the lab next door to my lab, my mentor's lab, was a postdoctoral fellow of Pat Wall in England. And Pat Wall came to visit us when I was a young graduate student in the early 1980s. And even then, it was a great honor to sit down and listen to this seminar. I got to talk to him a little bit.
So, Sonny, I have to ask you, I've read about them in the literature where they, and if this is true, I admire them even that much more, but they actually put neurostimulators in their suborbital foramen and stimulated themselves.
Well, those were the good old days when
yeah,
you could experiment on yourself. Yeah, those are true stories.
That's crazy. Anybody that's got that much conviction and passion about it, you have to take your hat off to.
And it was such a crazy thought at the time, but, it explained a lot, right? The most obvious one is you bang your knee and the first thing you do is rub it. You rub your, and that's activating the gate.
Right. Makes a lot of sense. So, if any more summation, Scott, of Scheide's paper here, because this is a big deal.
It kind of probably deserves its own hour, and I'm really not prepared to do that at this point. But I sure think that in the future it would be a good thing, because he's he's putting the lie to all of this stuff that surgery can't be helpful.
Well, I think we need to do that. I think we need to maybe, because this is such an important piece of research, that it should have a dedicated episode to it. So we'll definitely, we'll try to get that on the calendar in the future. But I guess in wrapping this up, you look at all of this data. Granted, a lot of it is, observational, maybe not the highest amounts of rigor, but from many, many sources, many surgeons, many objective findings that, improvement in motor function, improvement in, or restoration of sensation. These things they're not placebo effects. And I think the data is so big now that it would be hard for neurology or endocrinology to really push back on this if there's an open conversation. If you had, an endocrinologist and a neurologist that were sitting at the table with us, they were open-minded enough to actually look at the science, I don't think it would take them very long to go, oh yeah, that makes a lot of sense. Because how many neurologists are there in the world that will send a patient with diabetic peripheral neuropathy and they have carpal tunnel syndrome and they have pain in their hand because of the carpal tunnel syndrome, and they also have diabetic peripheral neuropathy, and they'll send them to the hand surgeon for a decompression. And guess what? That patient gets better. They get the sensation back in, 2.5 of their fingers. So there's no conceptual problem there from that standpoint. But when you ask them to look down to the lower extremity, it's like all of a sudden you're asking them to jump across the Grand Canyon or something.
Exactly. Yeah.
It's crazy.
Well, I hope that one thing is the editor at this Advances in Wound Care is pretty excited about what we are laying out here. So I hope that we'll be able to kind of diffuse the thoughts to the people who just haven't been able to see it in the past. And these co-authors, along with Shai Rosen, they are neurologists, they are endocrinologists, they are PM&R people. So having those names on the paper, I think, should be helpful, but we'll see.
Well, I guess we just have to get them, in a bronze plate or something like the 10 Commandments, and we carry these around, and if they won't listen, we kind of just maybe tap them gently on the forehead.
Whatever it takes.
An interesting aside is Dr. Sen, who's the editor-in-chief of Advances in Wound Care, which published our paper, was very kind to us throughout the process and expressed a lot of interest in letters to Scott. And they sent it to reviewers. The reviewers got back to us very quickly. We modified our manuscript, sent it in, and within a week and a half, they published it, or accepted it anyway, for publication.
And it's on preprint accessible. Yeah.
Yeah. So, Scott and I ran a quick experiment. We said, well, so our paper is a critical review paper in the journal, and I think there's only one in each issue. And so we looked at the previous 2 or 3 to see what the response rate was for them. And on average, it was like 4 months. And we got ours done in about a month and a half total. And, more interestingly, a week and a half after we resubmitted. So I think there is a lot of interest here, at least by this editor-in-chief.
Well, that's wonderful. I really appreciate what you guys are doing, because, there's always the clinical battle and the academic battle. And I think we've won the clinical battle. I don't think there's anybody that's in the clinical arena that's doing peripheral nerve work, whether they're upper extremity hand surgeons, plastic, or they're, more podiatric, orthopedic, lower extremity. I don't think anybody's going to argue with this that's already in that arena. I think it's all of the other folks that are not having the luxury of being in that sandbox play. They don't have a real good frame of reference. So I think this is wonderful work that you guys are doing. I'm so appreciative of what you've done and taking the time to come on today. It's been very, very good.
Thank you, Steve. Steve, I have a question for you. Maybe a good closing question. So what I tell doctors and nerve surgeons, or when I talk to them about this, it sounds like a pretty straightforward, almost simple procedure that doesn't take much time. But I tell them, look, it's not the surgery that's critical; it's the patient selection and running the tests to determine who would benefit. Could you talk a little bit about that and how important that is?
Yeah, no, I think patient selection is really the difference maker in a lot of the things we do, not only in peripheral nerve surgery, but in, pretty much any type of surgery. If you're going to have somebody that's not going to be compliant, or, if there's a lot of psychological issues, those are things that all have to be evaluated. I remember in my training way back, they always said, never operate on a patient who takes an antidepressant. Well, if we would live by that today, it'd be about 90% of the patients would not be meet that inclusion criteria today. But I think, one of the things is that if they still have some neurological function, they may be tremendously neuropathic, but if they're way out on the scale, they're probably not going to get as good of a result, because the restoration of sensation seems to be more limited than the reduction of pain. More than 90% of the time, we'll get a reduction in pain. So you have to ask the patient, what is it that you're really looking for? And if they say, I have this burning sensation, I don't have pain, that may be, a small C fiber situation where you're just not going to get a benefit from a nerve decompression. But if they have motor weakness and, significant amounts of pain, they're usually very good candidates, even if we fall down in the area of restoration of sensation, because they're so happy about not having this horrible pain and being able to sleep without the sheets driving their toes nuts, those types of things. So I think there is a lot of patient selection. But one of the things is that if we can educate them on the process, now we have to water it down here quite a bit, and they understand what we're doing, and then they want to buy into additional things, because there's no magic bullet in surgery or medicine. The patient still has to be optimized otherwise. We talked about nitric oxide earlier. I don't know why it took us so long, but we supplement. We try to get everybody to supplement nitric oxide supplement, because we know at age 40, they have about half the NO production that they had when they were 20, and each year drops like 15%. So it's just like other things like testosterone that decrease as we get older. But the point is that we're trying to optimize these patients from a metabolic standpoint, in addition to what we're doing from nerve decompression. So I don't know if that answered the question, Sonny, but that's kind of how we look at it.
Yeah, and the only thing I would add is a lot of the technique for conducting patient selection and the tests are trained at the AENS annual meeting.
Right. Yeah, and that's one thing I think we should mention to everybody, is that if you do have any interest in this, which I think you should have, you need to come and get involved with AENS and hear, people like you, Sonny, and Scott, and bring this research, talk to other clinicians. It's a life-changing practice, where it changes lives from a practice standpoint, for many practitioners that have come and discovered the nerve pathway. And I don't want to sound too evangelical here, but it's amazing. I've actually run some people to the meeting and said, hey, if this doesn't change your practice, I'll pay for your expenses for the meeting. And I've never had to do that, because it's like, wow, they thank you for getting them involved into this. So yeah, so definitely go to the ans.us website, take a look at it, and encourage everybody to come to the annual meeting, which is coming up in late October in Key West. So that should be a lot of fun. And I know you guys are going to do a special segment in that meeting on just this.
Looking forward to that. I don't think I've told him, Steve, but my back has gotten bad, as well as the progression of the metabolic only component of the diabetic neuropathy. So I don't really like to travel anymore. And I ended up having to have a spine fusion here a couple of months back, which, got me somewhat better, but not to the point where I'm ready to dance much. And so if I don't feel like I can get there to Key West, which I'd love to do, I hope they'll find ways to include me with Zoom, like we've had some of our Nobel Prize winners in the past.
Yeah, so exactly. So you'll be there, whether it's virtual or, they might even have hologram technology that.
I don't think I'd allow myself that.
Well, gentlemen, thanks so much. I always love hanging out with you guys, and I learned so much. I really just am thankful that you came on the show today, and I think people are going to really like to hear what we've said today.
It's been a pleasure to have an opportunity to talk about it to a larger audience.
Yes, thank you, Steve.
Thank you, Sonny.
And now a message from our sponsor. Well, folks, if you're over 40 and you're not using a supplement to augment nitric oxide production, you should really rethink that. This molecule is absolutely imperative to health, not to mention the cardioprotection. Nitric oxide is a physiological molecule that does so many things for your health. I never miss a day of nitric oxide supplementation. That's how important it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, just go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pod of Inquiry. Use Pod of Inquiry at checkout after registration, and I am certain you will be pleased not only for yourself, but for all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see that nearly every one of them will be deficient. When they see this result, they will want you to start them on it immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates. Thanks for watching. You can start today.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, podofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.